we're going to move on now and switch gears a little bit. My partner, Christine Jensen, from out on the north side of our practice, will be talking to us about local excision for rectal cancer. Does technique matter?
So thank you. Similar to Kareem, I'm going to change the topic of my talk just a little bit for a couple of reasons. One is that there's actually not a lot out there about different techniques for local excision and data as to what the technique should be. And then also I think actually in this country there's an increasing uptake of local excision. And I think it's very important to be choosing your patients carefully for local excision and determining whether they're appropriate candidates. So I wanted to speak to that a bit because it doesn't really make a lot of sense to focus on different techniques for local excision if we're not even picking the right patients for it. So why would we do local excision? So even 14 years after TME for rectal cancer, patients have a decreased health-related quality of life compared to the general population. There's a high rate of sexual dysfunction after rectal cancer surgery. So the proportion who are sexually active decreases by almost 50% after surgery. APR also has a greater negative effect on sexual function than anterior resection or transanal excision. And these patients that you're thinking about local excision on, ideally these should all be patients with tumors low in the pelvis that would otherwise be getting an APR. Also, you have a risk for hernia and bowel obstruction down the road. So local recurrence, if you do a local excision, depends quite a bit on T stage. So you can see over in the first column here, T1 tumors, the rate of local recurrence varies quite a bit, but might be acceptable depending on what study you're looking at. Whereas if you're looking at T2 or T3 tumors, the rates of local recurrence are really unacceptably high. And then in studies that compare local excision to TME, you can see for T1 tumors, even for T1 tumors, there's a definite difference in local recurrence rates for local excision versus TME, with these rates being quite a bit higher for local excision. And then once you get to T2 tumors, the rate of local recurrence is unacceptably high. So really, ideally, patients who are being considered for local excision should only be T1 tumors with favorable pathologic features that are generally low in the pelvis. And then also, if you do local excision and the patient recurs, you've actually done your patient a disservice. So surgery done for recurrence is extensive and morbid. And survival after surgery for recurrence is quite poor. So these are three of the large studies looking at TME after a local excision for recurrence. In the YO study, the 3-year re-recurrence-free survival rate was only 43%. In the WISER study, the 5-year disease-specific survival was 53%, and in the Bic-Chandrani trial or study, the 5-year recurrence-free survival rate was only 47%. So you're taking patients who otherwise probably had a very good prognosis to start and actually doing them a disservice if they recur. And then similarly, if you are to do a TME after recurrence, these tend to be very morbid, so there is reassuringly a pretty high rate of R0 resection, but a very low rate of sphincter preservation, as you might expect, since these were probably low tumors to begin with. And then a fair number of patients require actually a multivisceral resection. So despite all these concerns and needing to focus on selecting our patients appropriately for local excision, this is increasingly being done across the country. So you can see for stage 1 cancers, local excision is now about 50%. And even for stage 2 tumors where local excision probably is really not appropriate unless it's a very selected case, this is greater than 10% now. And then if you break down the stage 1s even further, you can see that the patients that might be appropriate for a local excision, the T1, well differentiated, it's about 50% are getting local excision, whereas T2 tumors, which I would argue are likely not acceptable for local excision, are actually up to 20% are getting local excision rather than TME. So transitioning back to the original topic of the talk, which is what's the approach we should use if we are going to do local excision. So there is some data out there to guide us. So for T1 tumors, looking at TEM, there are studies looking at TEM versus anterior resection. So this is a randomized controlled trial with a 46-month mean follow-up. And the local recurrence in both arms was quite low, actually 0 in the anterior resection side and only 4.2% in the TM side, and survival was identical. So TM might be a reasonable alternative for T1 tumors. For T2 tumors, this is a study by Lazoche et al., a randomized controlled trial of 70 patients with T2 and 0 cancers, TEM versus laparoscopic resection, and this was done actually after chemotherapy and radiation, not non-radiated patients. They had an 84-month median follow-up, And the local recurrence was actually relatively similar and quite low, and survival was good also. But I would take this study with a grain of salt. This is done after chemotherapy and radiation, which I would say that this is not an approach that's standard. There's some significant downsides to this that we could talk about. So what's our experience with TEM? So we had 95 patients followed up over a median of 49.5 months. And our local recurrence for T1s, you can see, is perhaps acceptable, 9.8%. But once you get up to T2 and T3, even though these are smaller numbers, it's really a very high local recurrence rate. So what about TEM versus transanal excision? So this is another one of our studies looking at stage 1 rectal cancers with a median follow-up of 60 months. More patients in the transanal excision group, 129 versus 42. There were no significant differences in the patients or the tumors except for the tumor height above the anal verge, because as you might expect, transanal excision, there's a limit as to how far up you can get, whereas TEM expands your range as to the tumors you can excise. And the 5-year disease-free survival was 84% for the TEM versus 76% for the transanal. So some suggestion of a difference, but that was actually not statistically significant. And as you might expect, distance from the anal verge, margin status, T-stage, and use of adjuvant therapy were all independent predictors of local recurrence and disease-free survival, but the approach was actually not an independent predictor of survival. And then there's not a lot of data for TEM versus transanal excision, and there's even less data for TAMIS. So just looking at our own data, we recently had a paper accepted looking at T1 N0 tumors that were locally excised and followed by ultrasound. We had excluded those that were stages greater than T1 N0 preoperatively with the idea that if people were selected to have local excision, there might be some factors that guide that. And we also excluded those who had less than 3-month follow-up. So as you can see, unfortunately in our group we only had 3 TAMIS, but reassuringly there were no local recurrences. And then the TEM and transanal both have more substantial numbers of patients, 36 and 75, and the local recurrence rates, even with these smaller numbers, seem to be relatively similar. And then of course there's the new kids on the block, robotic TAMIS. So if you take TAMIS and the robot, it must be better, right? So unfortunately, in conclusion, I think there's not necessarily a lot of data to guide us in terms of the best approach for local excision. I do think probably the gold medal winner for T1 tumors is actually still total mesorectal excision. That has the lowest local recurrence rate. But if you are doing a local approach, I think there is some suggestion that you might have better results with transanal endoscopic microsurgery. But I do think it's difficult to demonstrate this because in general the local recurrence rates are low. So in order to demonstrate a difference between different approaches, you need a very high number of patients to demonstrate a significant difference. And then I think third prize goes to transanal excision, and then runners up or to be determined robotic TATME or TAMIS. Thank you.